So let's talk about CNS disease. It's ALK-rearranged lung cancer. It does have a proclivity to go to the brain. This is not an uncommon event like we see in the EGFR mutant lung cancer patients. Josh, just some comments on how you manage CNS disease for ALK-positive patients. Trust the drugs, hold off on whole brain. Is there a particular agent, and Ross, maybe you can comment as well, on which drugs may have better activity in the brain?
So this is a similar story to what we were talking about before with osimertinib. I mean, both brigatinib and alectinib have fantastic CNS penetration, and we saw in the trials that were presented there were CNS responses, there was control of disease, and also, like the osimertinib story, sort of changing from erlotinib, gefitinib, which don't have great CNS penetration, and crizotinib, which doesn't have good CNS penetration, to the newer drugs which do. And so I do tend to trust in the drugs, and I'll say if a patient has brain metastases, I will start them on the TKI. We'll work closely with the neurosurgeons and the radiation oncologists as needed for monitoring closely, but avoiding whole brain radiation therapy at all costs, and seeing what we can do with the drug and maybe some SRS.
Ross, you presented the data at World Lung and subsequently published. Is there a hint that brigatinib may have better CNS activity than alectinib, or we just don't know?
You know, again, it's hard to compare, but with the caveat again that you're expecting the data to look slightly worse because it's more immature, and yet the hazard ratio amongst those with brain metastases was already better than alectinib. Alectinib was 0.4 at the same time, and this was 0.2. I mean, they're just amazing numbers. Although I have to say, I don't think either of them is the best drug in the brain. I actually think lorlatinib is the best drug in the brain. I mean, it's quite phenomenal how much of it gets in. And I've actually had patients who, although they've done fabulously on alectinib or brigatinib, when they progress in the brain, lorlatinib can salvage them in the brain. That's its real strength.
Yeah. So, you know, I have, interestingly, not used brigatinib that often. I've stuck to alectinib. I'm curious to see what brigatinib would do in a treatment-naive patient compared to what I see with alectinib. You obviously have a little more experience, but we'll see. It'll be interesting to see how this data shakes out and how the mature data comes out for the brigatinib.
Or even if lorlatinib moves to the first line.
Yeah, and I mean, a crowded space. So let's talk about different drugs and sequencing and how we do that. Patients, obviously, they're on alectinib as standard of care. You know, what do we do next? You know, do we biopsy all patients post-alectinib or brigatinib? Do we do plasma genotyping on these patients? What's your common practice? What's the message to the community?
So if you're on alectinib, so you're like the vast majority of people who are ALK positive and they start now and they're going to start on alectinib and then they progress. And sure, there are going to be some situations where it's oligo progression, you're going to zap with radiotherapy and keep them on the drug. You know, because why you know, move away from a good thing if it's just a tiny little bit that's growing. The only licensed drug post a next generation inhibitor is lorlatinib, where it probably has about a 40% response rate. The FDA label is actually somewhat misleading. It quotes a 48% response rate, which includes people who've only had crizotinib, which is actually not in the label, and they do better, so they float up that number. But I actually don't rebiopsy. I mean, if for research purposes, you know, we'll rebiopsy and we'll send them to Bob's lab, but we don't need to, because what's your choice?
Right.
I'm going to go on lorlatinib or chemo, and so I'm just going to try the lorlatinib.
Yeah. Bob, go ahead, Josh.
Yeah, so, you know, one of the exciting trials that's now just being activated is the ALK master protocol to try and really formally look at this, right? Because none of the labels mandate that you biopsy or have a particular resistance mutation. I think we think we understand a lot about how to match these drugs and which ones are resistant to which. But the ALK master protocol, I think, is going to help us answer, I think, a lot of intriguing questions. Like, what happens if you don't have a mutation? Is lorlatinib the best option, or is chemotherapy? What happens if you have MET and some of these other options? Also, it's going to answer the question of, you know, tumor versus ctDNA. We're going to look at correlations in that. And so I think that might help us. But I think right now it's very reasonable to just proceed to another ALK TKI in the absence of a biopsy. I think, you know, we're learning a lot from this, and I think it's ultimately going to help us treat our patients better. But right now you don't have to do it.
I would say, though, that if lorlatinib is different from alectinib and brigatinib, in that the toxicity is greater. I mean, the side effect profile is worse. So if I had a biopsy that showed that there was a resistance mutation, which at least in vitro is sensitive to brigatinib, I would be tempted to, rather than switching them to lorlatinib, to give them brigatinib.
And what side effect profile are you concerned with lorlatinib?
So lorlatinib is associated with sort of CNS effects, confusion, confusion. There have been reports of altered mental status sort of situation, as well as there's elevated lipid panels. That doesn't worry me as much, but the confusion in altered mental status is, I mean, as we discussed, these are patients who are living with these side effects for a very long time. And if I can avoid having to expose someone to that toxicity profile, I would like to.
I agree. I mean, I think it's something that can be problematic for patients, usually managed with, dose interruptions and sometimes dose reductions, but it's kind of a unique side effect, I think, among the drugs that we're used to seeing, and something that requires kind of counseling and, close communication with patients. I've actually had, it's not so much the patient that comes in and complains about it, but their family members who say they're just not quite themselves. And it's something that patients don't always attribute to drug until you actually say, this really is drug related. They say, well,
there's
this person's just...
there's a kind of mood and personality, but even the speech slowing. I mean, I've never had a drug where I can tell what drug someone's on just by talking to them. Yeah. Because there's a very distinctive speech pattern they have.
But generally, manageable for most patients, I think, with dose interruptions and dose adjustments. So, I think something to watch for, but not prohibitive for the majority of patients.
So if patients are started on alectinib, just backing it up a little bit and just high-level clinical overview, next drug to treat them with, everyone's in agreement, the data is most with lorlatinib?
Well, lorlatinib's the only one that's licensed, but at this ASCO, we saw a 104-patient study from France, which showed a 50% response rate with brigatinib post next-generation inhibitors. We saw a smaller study that Bob and I were associated with that had a 40% response rate post next-generation inhibitors. Last World Lung Cancer, there was a poster that showed a 70% response rate with brigatinib. And then there's a smaller study that showed a 17% response rate. So clearly there's heterogeneity.
Right.
But at least the nice thing is that as these small data sets start to move, it's moving more towards the middle, a sort of 40 to 50% response
Probably
rate.
depends on some on the spectrum of resistance mutations,
Right.
right?
Yeah.
And that's where the biopsies would probably
Yeah,
help
if you put all the wrong patients on, you have a 0%
but
response rate.
I feel like the way that the ALK trials have been structured has been independent of the resistance mutation. I think that was probably driven by the fact that in crizotinib, because many patients who progressed on crizotinib did not have a resistance mutation because it wasn't very, the affinity for ALK wasn't very high. So you weren't really pushing on that. You weren't developing resistance. So everyone was responding to the next one. So you didn't need to limit. Yeah. And so now as a result, we have these indications, and I feel like we're flying blind. And so what I see when we see 17%, 70% is more like what Zosha was describing. So I have no idea who these people are. Yeah. And I think that it implies to me that having that biopsy and resistance data would be critical.
I mean, what I actually think most of that is, if you look at the data that came out with lorlatinib, that if you could find a mutation, you had a 60% response rate, and if you couldn't, you had a 20% response rate. Now, 20% tells me we're not as good at finding mutations as we think we are, but clearly that's part of who determines.
Oh, yeah.
Right, and that gets back to the question of what's the best therapy, because if it's really 20%, then chemotherapy might be a better option, and that's something that this new trial, the ALK master protocol, will answer.
So many questions to answer sequence-wise, and this genotype.
So much to talk to in future years.
It's just, and
We've got another 3 hours to talk about.